This is my Cat Iii psoas test.
And then if
So I'm going to have the patient supine. I'm going to have them stretch their hands up above with being de-artifacted, no jewelry, with IS traction, pull. Put the hands together. I'm going to note the shorter side, and I'm going to go on the contralateral side of the short side. So sitting on the side of the table, relax. Other side. And I'm going to find the psoas muscle with my minutes. As I'm doing this, I'm going to have them breathe in and out. On inhalation, I'm going to press in, A to P. And exhalation, I'm going to and also move the leg out. On exhalation, I'm going to pull it in, have them exhalate or breathe out, and I'm going to hold the same pressure. So breathe in and breathe out. Breathe in. 20 for each time. Breathe in, follow them in, and breathe out. We do that 2 to 3 times, and then I'm going to reassess the psoas again.
No.
Eat the chair. My glute fiber analysis. You're going to turn on your stomach. I'm starting at the PSIS. That's the area that's correlated with L5. So L5, and as I'm palpating, I'm going to palpate up on the iliac crest, increasing with pressure, asking the patient if they notice any difference in pain. 5, 4, L3, L2, L1. If you're noticing here, I'll take note of that. Same on both sides, L5, L4, L3, L2, and L1. I'm going to find which side is more tender, and I'm going to use that and actually take note of that so whenever I'm blocking. So, and I'll correlate that with the 11 brother analysis, or the 11 brother chart. So let's say that L5 was sore. We're going to correlate that with C1. I'm going to then palpate the TVPs, and depending on which side, I want to make sure that I know what they indicate and tell me what side is sore. I then can go back and correlate that with the L5 lumbar or the spinous. C1 doesn't have a spinous process. So my indicators for category 3 is going to be me asking if the patient has a tender. I'm going to actually grip to see if the calf is tender on both sides, if the hamstrings, and then I'm going to also palpate the glute to ask for if there's soreness in that area as well. And then as I follow up, I'm going to follow up at the temporal sphenoidal line to TS line, which is right here by where the glasses would lay. And I would palpate and ask them if there's any tenderness on that side here, as well as the other side. Now I'm going to perform Sot Hall. And Sot Hall is based on the indication of sciatica. It's an indicator, and it's also therapeutic. So, I forgot what I was doing. Okay, so I'm going to have the superior hand above the ankle, and the superior hand, or my inferior hand is going to be above the ankle, and then my superior hand above the knee. This process is going to take 15 seconds. I'm going to pull out close to me about 14 inches or until there's gluteal bunch. And then I'm going to also rotate the ankle. I'm going to do this for 15 seconds. And then as I bring it back in, slowly, I'm going to wait about 2 minutes in between, and I'm going to repeat the same thing. What I'm going to ask the patient is if they notice a difference between the first time and the second time. If they notice that it got better, that gives us the indicator that it's piriformis, and so for treatment we will actually do that up to 2 or 3 more times until the piriformis, or until they notice that there's no change in between 1 and 2. And then if they notice that it gets worse, that indicates that it is a sequestered disc, and then we will refer out to an orthopedic surgeon. If they say that they couldn't tell the difference between the first and the second time, we would then know that it is either a subluxation or a herniated disc.
You're kind of ballistic.
Okay, so I'm going to set my patient up for blocking. I'm going to have the pelvic board here, and I'm going to have them go prone with it being 4 inches above the iliac crest. And also a sternal roll will be comfortably underneath the chest as well. So I'm going to check to see which leg is the short leg. You press out, relax. Okay, so for the purpose of this video, we're going to use the right leg as the short leg. So with that, what I'm going to do is do a non-assisted lift of the leg. Do you have any knee problems?
No.
Okay, making sure they don't have any knee problems. This is going to go 45 degrees underneath the trochanter. And on the long leg side, it's going to go at a 45-degree inferior under the ASIS. So they're both going to point down. I'm going to do the posterior iliofemoral test. What I'm going to do is, at the patient's still going to be resting and blocking for a total of 30 minutes. During this time, I'll be doing these. I'm going to rotate the ankles inwardly, and I'm going to find the difference, see which side has the more restriction. And so, for the purpose of the video, it's going to be the right side. And with that, I'm going to, since it's the short side, I will remove the block for this purpose. It'll be the only time I remove the block to make sure that I'm not in the way. And from the other side, from the same side, I'm going to use a double thumb approach, and I'm going to be thrusting into the opposite obturator. So, replace the block. And I come back to recheck, and it'll actually be more even on both sides. The lumbar derotation is found whenever I originally did my glute fiber analysis, and I correlated that with the 11 brothers. And in the VW chart, I found with the derotation that it was a spinous that had a pressure. So with that, if it was on the spinous pressure, after doing the glute fiber analysis, I would press to see which side was more tender. That would give me my indication of which side the derotation is found on. So for it being on the right, it was more tender. I would then remove the block from that side, allowing it to roll in. So the rotation was on the right here. I'm actually allowing the spinous to roll in when I remove the block. So for the lumbar inferiority, I would do the same thing of how I found the derotation, but I would be contacting the mammillary of that area. And I would pump the leg as well and do an I to S thrust or a push. It's almost like anchoring I to S. Each time I'm going to hold for 5 seconds. I'm going to do a total of three tries. Acetabular goading is going to be based off the indication of sciatic pain. If it's on the side of that's on the same side of the block, I would remove the block, but it just consists of me goading in that area of where that sciatic pain is found. I'm going to do that until there's no more pain, or you can't tell the difference between if the pain is getting better or worse. So orthopedic blocking is based off an indicator for cervical TVP tenderness. Based off of that side that I found, I'm going to remove the block from that side. So I found it on his left side. We're going to move the block from the left side. Okay, so we're going to wait a total of 2 minutes for that, and then we're going to replace the block. For sciatic traction, there has to be an indicator of sciatic or acetabular pain. So what I'll do, if you had sciatic pain on the right side, what I'll do is I'm going to traction as the patient tracks at the head of the table. For 5 seconds, I'm going to pull, and then I'm going to release slowly for 5 seconds, and then I'm going to continue to pull. We're going to do this a total of 3 times, and if I wanted to have an assistant, if it would to be more effective, I'd find the lumbar spot. I'd have my assistant pull with the 5 seconds, and I would actually go on the lumbar spinous, and I would anchor up with an I to S push as my assistant is pulling S to I. A total of 3 times each. So post block, we remove all of the blocks. We would follow the process or the steps of doing the sacral base and sacral cup, which has been explained in category 2. Then we'd also do the sitting disc, which I'll have my patient sit up and face to their left. Sitting disc is going to consist of them holding their chin to their chest, and on inhale, they're going to arch their lumbar spine and inhale and push back. On exhale, they're going to keep their chin to their chest and extend their back. I'm going to have them do that a couple of times. With me, I'm going to actually find the lumbar spine, the spinous process. On inhale, I'd go I to S as they're breathing in, and then on exhale, I'd go P to A with the pressure. After we've done this for about 3 to 4 times, I'd do the side posture. The side of the leg will always be down, and the spinous process will be rotated towards that side if it's a rotational correction we need to make, or the open wedge will be towards the sciatica side. So since this is right side, I'm going to have him in right side posture. So what I'm going to do is set him up like a normal diversified adjustment. Except the leg will not go tucked in. My knee will be in the popliteal fossa. So if it was a rotational, I would be on the mammillary process as I have here. I'll be on the mammillary process, and I would be going P to A. And if it's a